In this seminar, we'll talk about influenza. As you know, influenza is caused by three different types of viruses, namely influenza A, influenza B, and influenza C. Each one different characteristics. For example, influenza A can survive in humans, swine, equine, birds, marine mammals. Influenza B, it affects only humans, and influenza C can present in humans and swine. In addition to what is their natural host, they also have some epidemiology characteristics. For example, influenza A can have antigenic shift and antigenic drift. What is antigenic shift? The antigen variation from one season to another one will be completely different. That means the human beings or population is completely not exposed to that new antigen. That is called antigenic shift. When there is a big difference in the antigen exposure to completely naive population, it can cause large pandemics with significant mortality in younger persons. On the other hand, influenza B has only antigenic drift, meaning there will be antigenic variation, small amount. So the population is have some protection against influenza B, not drastic as it happened with antigenic shift. As a result, it can cause severe illness in older adults and on those patients who have high risk factors. Pandemics not seen in patients with influenza B. Influenza A not only causes pandemics, it can also can cause seasonal um, drift, like what we can see with influenza B. On the other hand, influenza C does not cause seasonality of infection, but it causes only antigenic drift, often causes milder infection when compared to influenza A and B. This picture shows the increased hospitalization in the extremes of age. The hospitalization more commonly seen in patients less than 5 years old and also the patients more than 65 years old. As you can see here, less than 5 years, more hospitalization. After 65 years, the incidence goes very high. This graph shows the clinical symptom score and also corresponding interleukin and other cytokines elevation and decrease. As you can see, the symptoms should be worse in the first 2 3 days of the illness, then slowly come down. It completely disappears by the end of the week. So does the cytokines, interferons, TNF, and interleukins all surge after the infection and subsides after 7 to 10 days. So the clinical manifestations of influenza are sudden onset of fever, unproductive cough, chills, rigors, diffuse myalgia, headache, malaise, and also other respiratory symptoms like sore throat, nasal congestion, rhinitis, cough, and less common symptoms like abdominal pain, nausea, vomiting, diarrhea, and sometimes acute myositis. In infants, it can cause sepsis like illness. This table shows varied manifestations in different age groups. In infants, different set of manifestations. In pediatrics and children, different kind of manifestation. In adults, you will have completely different set. In adults, predominantly you will have fever, cough, myalgia, sore throat, headache, and conjunctivitis. In smaller infants, and predominantly gastrointestinal, anorexia, diarrhea, vomiting, in addition to malaise, lethargy, and conjunctivitis. more common. And in children, the manifestations, depending on the age, can vary, kind of in between infants and adults. Most children recover fully after 3 to 7 days of illness. Complication can occur even in previously healthy children, even though it runs a severe course in high risk patient. Even in a normal healthy children, you can have severe course. Neurologic complications such as febrile seizures to severe encephalopathy and encephalitis with status epilepticus can be seen in patients with influenza. Reye syndrome used to be very common, but it's often seen in patients with idiopathic arthritis and Kawasaki disease. The reason being they are often being on salicylate containing drugs. And death from influenza has been seen associated with myocarditis. This is the most common complication of influenza, secondary bacterial infection with Staphylococcus aureus, Strep pneumo, Group A Staphylococcus, and other bacterial agents can cause severe disease and death. Influenza is highly contagious and spreads from person to person, primarily through large particle respiratory droplet transmission. Coughing and sneezing can spread the infection. Droplets can remain viable for up to 24 hours. The patient may be infectious 24 hours before the onset of symptoms. Viral shedding in nasal secretion usually peaks during the first 3 days of illness and ceases within 7 days. But in younger children and immunocompromised patients, the prolonged shedding, such as 10 days or longer, can happen. Regarding seasonality, in the United States, the influenza activity occurs from October to May, and peaks usually happens in the December and February. And seasonal epidemics can last up to 8 to 12 weeks or longer. This more so when there are 2 or 3 influenza virus strains in the community associated with prolonged influenza season. It can produce bimodal peaks in activity. It is estimated 8% of the US population develops symptomatic influenza like illness. And the highest influenza happen in children, 10 to 40%, especially in the school going children. Higher incidence of influenza has been reported. The hospitalization rates are higher among children less than 5 years and older individuals more than 65 years. Children younger than 2 years consistently have higher risk of hospitalization and they run severe course of illness, similar to older adults 65 and above. Hospitalization morbidity often caused by the complications such as pneumonia. High risk patients more affected, but 40 to 50% of all children hospitalized do not have any other underlying high risk factors. Almost half of the children who die from influenza do not have high risk patients. So, in extremes of age, treat them with caution because they can run a severe course in the absence of any high risk factors. As we discussed earlier, pneumonia is the most common complication and most common cause of death in patients with influenza. There are 3 kinds of viral pneumonia that can happen with influenza. One is primary viral pneumonia. So typically, we told the symptoms worsen 3 to 5 days and the symptoms get better. But in patients with primary viral pneumonia, there is a relentless progression from classic 3-day illness of influenza. The chest x-ray showed bilateral streaky infiltrate. It will not show consolidation. The mortality is very high. The treatment is antiviral treatment and supportive therapy. On the other hand, secondary bacterial pneumonia, the typical course would be there will be initial improvement, then worsening after third or fifth day. It often caused by pneumococcus, staph, and H flu. Chest X-ray will show consolidation. Mortality is very variable. Antibiotics, early initiation of antibiotic will decrease the mortality. And the third category is mixed viral and bacterial pneumonia. It can be associated with the ARB, influenza ARB. Chest X-ray will show consolidation, again caused by pneumo, staph, and H flu. Chest X-ray will show consolidation, and the mortality is variable. Early initiation of antibiotic along with antiviral medications will reduce the incidence of mortality. In addition to the pneumonia, the other systems also involved in patients with influenza, namely cardiovascular. It can cause cerebrovascular accidents, ischemic heart disease, and myocarditis. Hematologically, it can cause hemolytic uremic syndrome, hemophagocytic syndrome, it can cause myositis, rhabdo. Neurologically, it can cause acute disseminated encephalitis, GB syndrome, post-influenza encephalopathy, those myelitis. In the eye, it can cause conjunctivitis, that's the most common one. It can cause optic neuritis, retinopathy, and uveal effusion syndrome. The lung, in addition to pneumonia, it can cause ARDS, diffuse alveolar hemorrhage, hypoxic respiratory failure, and primary and secondary bacterial pneumonias. Kidney, it can cause acute kidney injury and multi-organ failure. This slide from American Academy of Pediatrics published in July 2024. As you can see here, 2019 to 21, sorry, 2020 to 2021, 2021 to 22, there is a decrease in incidence of deaths related to influenza because that times we had COVID-19 pandemics. Then afterwards, it causes close to 200 deaths in children has been reported. Regarding diagnostic tests, the sensitivity and specificity of any influenza test varies by the type of the test used, the time from illness to the onset, and specimen quality, source, and specimen handling and processing. All those can affect both sensitivity and specificity. Most of the time, NP swab specimens, nasopharyngeal specimens have highest yield. Mid-turbinate nasal swab or swab specimens also acceptable. In intubated patients, one can use bronchoalveolar lavage. Non-respiratory specimens such as blood, plasma, serum, CSF, urine, and stool should not be used for routine diagnosis of influenza. These are various tests available, and as you can see, the methodology may be very different. Some of the tests use antigen detection, others molecular and amplified nucleic acid amplification, and the viral culture. If you want to have yearly quick diagnosis, the antigen detection test is often used. This is the most common test used in emergency department and ambulatory care settings. It detects both A and B. Sensitivity is only moderate. In the hospitals, often used tests are and PCR. Again, waiting time is not that long, 15 to 30 minutes to 1 to 8 hours. Sensitive high, it detects both A and B. So how do we treat? Oseltamivir is the preferred antiviral medications for patients with A and B. FDA has approved oseltamivir for influenza treatment in children as young as 2 weeks of age. The oseltamivir is available in the United States as Tamiflu. Initiation of antiviral therapy should be based on signs and symptoms consistent with influenza infection and the epidemiology factors. Provision of antiviral therapy does not require positive test of infection. In addition to oseltamivir, we have inhaled zanamivir for children 7 years and older, and also intravenous paramivir is approved for patients 6 months and older, and oral balaxavir is approved for people 5 years and older. The resistance has been reported with oseltamivir and zanamivir in less than 1% of the patients. Most of the patients, it works well. Regardless of the influenza vaccination status, the antiviral treatment should be offered as early as possible to the following categories of patients. Number one, any hospitalized child or the patient with suspected or confirmed influenza disease, regardless of the duration of the symptoms. The second category is any child, inpatient, outpatient, with severe, complicated, progressive illness attributable to influenza, regardless of the duration of symptoms or presence of high-risk conditions, they need to be treated. The third group, when there is a high risk of complications, regardless of the duration of symptoms, they needs to be treated. So any hospitalized patient with progressive illness and the high risk of complications, regardless of the duration of symptoms, they need to be treated with antiviral medications. Then under the two other categories, those who do not have a high risk of influenza, but they have suspected or confirmed influenza identified within 48 hours of illness, they need to be considered to be treated. And another group is children younger than 6 months or any other high risk factors for influenza complications. If they are suspected or confirmed influenza disease, they need to be treated as well. So there are 5 groups of patients recommended by Red Book 2024 to 2027 give antiviral treatment. The side effects are oseltamivir causes nausea and vomiting, zanamivir associated with bronchospasm, so it's not recommended for patients with chronic obstructive pulmonary disease, and balaxavir can cause nausea, vomiting, and diarrhea. There are 2 groups of antiviral therapy available. The one group, which is amantadine and rimantadine, acts on the protein target M2. It works against only influenza A. And also there are restrictions like amantadine is approved for patients above 1 year of age, and rimantadine is approved only for adults. On the other hand, the latest available medications, this acts on neuraminidase. It works against both influenza A and B, and in case of oseltamivir, it is approved to use more than 2 weeks of age. In case of zanamivir, which can be given via inhalation, it's approved for adults and children more than 7 years of age. And paramivir, those who cannot able to take by mouth, can be given IV 1 dose. It's effective against A and B. Balaxavir is pure medication and it's again approved for adults and children more than 12 years of age. So what are the doses? If you use oseltamivir, the oral for adults dosing is 75 milligram twice a day for 5 days. In children aged 1 to 12 years, the dose vary from 30 to 75 milligram twice a day, depends on the weight, for 5 days. For the details, please check CDC guidelines. It's given here. And when you use zanamivir, inhale orally, adults and children more than 7 years, 10 milligram twice a day for 5 days. When you have to use paramivir, it's intravenous. It is approved only for those who cannot take by mouth. Adult dosing 600 milligram IV once. Children 2 to 12 years, 12 milligram per kilogram once. Balaxavir, adults 80 milligram per once. Children more than 12 years, less than 80 kilogram, is 40 milligram once. If you want to do an influenza prophylaxis, if you use oseltamivir, adults 75 milligram per day, and children aged more than 1 year, 30 to 75 milligram per day, depending on the weight. Please look at CDC guidelines for different ages and the weight. Zanamivir for adults and children aged more than 5 years, 10 milligram per day. Paramivir, there is no approved indication for prophylaxis. This is the guide, side effects profile from Red Book 2024 to 2027. As you can see, oseltamivir, in addition to nausea, vomiting, they mention headache, skin reactions, diarrhea, especially in children less than 1 year. So, how to prevent? One, we talked about prophylaxis or with antiviral medications. And also, very important, annual vaccination is mandatory to prevent, especially in high risk patients, and also it's recommended for patients 6 months and above. There are two groups. In children 6 months to 8 years, they need to get two doses during their primary season. And patients above 9 years, they need to get one shot, irrespective of the prior immunization status. The flu mist also available, but it is recommended between 2 years to 49 years. Supportive therapy is very important in patients with influenza, the number one being control of fever with acetaminophen or paracetamol or another appropriate non-salicylate containing antipyretic agent. Please do not use salicylate containing drugs because that can precipitate Reese syndrome. Fever could exacerbate underlying chronic conditions. Children and adolescents with influenza should not receive aspirin or salicylate containing products because of potential risk for developing Reese syndrome. All people 6 months and older should be vaccinated annually against influenza. There are two kinds of vaccinations. One is inactivated influenza vaccine that's given via intramuscular injection. Another one is live attenuated influenza vaccine, which is given as a nasal spray. It comes in the name of flu mist. All influenza vaccines are formulated to protect against the viral strains circulating in that particular season. I just wanted to throw this slide. Even in the United States, with constant push for influenza vaccinations, only the best 60% get vaccinated. That means another 40% is exposed to the influenza disease. So it's very important as a primary care provider to insist on them to get annual influenza vaccination for all patients 6 years and above, and definitely for the high risk patients and also the patients with extremes of age less than 5 years and 65 years and above. AAP do not have any preference to use whether inactivated or live attenuated influenza vaccine. There are different kinds available. The most of the available vaccination in United States are egg-based, but there are cell-based inactivated vaccination too. As we have mentioned, there is a live attenuated influenza vaccine that is recommended between 2 years to 49. In elderly, that means 65 years and above, and high dose Fluzone is recommended. Then the non-high dose that is given to everyone else. In case if you do not have the high dose flu zone or similar vaccination, what is available one can give for all the patients. Children 9 years and older or require only one dose of influenza vaccine, regardless of their influenza immunization history. For patients between 6 months to 8 years of age, they need, for the first timers, received 2 doses and 4 weeks apart from one dose to another. The protection against disease is achieved 1 to 2 weeks after the second dose. So it is very important to start the first dose prior starting influenza season. Immunization is must for the high risk patients. The question is, what are the high risk factors in children and adolescents? Children younger than 4 years, children with chronic pulmonary like asthma, cardiovascular, except hypertension, renal, hepatic, hematologic, and metabolic disorder, including diabetes, and children who are immunosuppressed, including those who are infected with HIV and those who are taking immunosuppressive medication, children with conditions that can compromise respiratory function and handling of the respiratory secretion that can increase the risk for hypertension, and children who are receiving long-term aspirin therapy and who therefore might be at risk for developing Rh syndrome. They need to be vaccinated well in advance. Children who are residents of chronic care facility and those who will be pregnant during influenza season. All these patients are the high risk factors, so they all need to be vaccinated. Let's look at the high risk factors in adults. The person aged 65 years and older, women who will be pregnant during influenza season, persons with chronic pulmonary, including asthma, cardiovascular, renal, hepatic, hematologic, or metabolic disorder, including diabetes, persons who have immunosuppression, those who are on immunosuppressive medications, and HIV infection. Person with any condition that can compromise respiratory function or handling of the respiratory secretions or increase risk of aspirations all need to get vaccinated. And persons with obesity, defined as BMI greater than 40, residents of nursing homes and chronic care facilities, all need to be prioritized in getting influenza vaccination. Chemoprophylaxis. If not contraindicated, influenza vaccine always should be offered, even after the influenza virus has begun circulating in the community. The chemoprophylaxis is not a contraindication to get immunization with inactivated influenza vaccination. On the other hand, live attenuated influenza vaccine should not be co-administered with antiviral medications. These are the four recommendations. For oseltamivir and zanamivir, 48 hours before or 2 weeks after live attenuated vaccine one can use, but not in between those times. Paramvir, which is an IV medication, 5 days before or 2 weeks after live attenuated influenza vaccination. Baloxavir, 17 days before or 2 weeks after. So one has to follow strict guidelines, otherwise, the antivirals will inactivate the live attenuated influenza virus. Chemoprophylaxis is not recommended for infants and 3 months, but when the patient is critical, one can use. The reason it's not recommended because the safety and efficacy data is not available for that group. This concludes seminar on influenza, and we do give live seminars every Sunday at 6:30 a.m. Central Time or 6 p.m. Indian Standard Time. Please invite your medical students, residents, postgraduate students, specialists, and those who are interested in, and leave your comments and subscribe, share with others if you like our seminars. Thank you so much for listening.